Welcome back, and thanks again for joining me for today's webinar on treating shoulder impingement syndrome with laser therapy. My name is Dr. David Kunashko. I'm a chiropractor, and I am the medical director here at BioFlex Laser Therapy in Toronto, Ontario, Canada. A little bit of housekeeping before we get started. These webinars are always recorded so that in the future, if you want to go back to it, they'll be posted on our website, usually within a week or two. In this case, it's a professional webinar, so you'll need to look for archived professional webinars. I also do consumer types of or sort of, webinars for our consumer devices like personal therapy system, that kind of thing as well. And anyone can watch them, of course, because they are complimentary. I do have to apologize. I'm just getting over the flu, so my voice may be a little froggy here and there. So hopefully I won't sneeze into the microphone as I do today's webinar. And one of the reasons why I'm kind of going back to this type of condition is that it's extremely prevalent, this type of issue, especially as we get a little bit older. So you'll find it very common complaint amongst people coming in. They have shoulder pain, and especially when they're 40, 50, 60 and beyond. And dollars to donuts is probably impingement. And so, and it's notoriously difficult to deal with. Laser therapy can be extremely helpful along with other rehabilitation measures. So I will talk about those as well. I'll give a brief overview of the anatomy and, typical etiology and pathophysiology and the symptoms one can expect in their patients, along with, so conservative treatment, more so along exercises. That's probably what I would focus on. And then, of course, photobiomodulation or laser therapy, why this might be helpful, why it is actually helpful, some of the mechanisms behind that, and also how you would use your equipment, in this case, BioFlex laser therapy, in order to treat this type of condition. Should you have any questions along the way, type them into the chat box. I'll definitely get to those questions at the very end of today's webinar. I love questions. They're quite informative. Try to keep it on topic today. I'd really appreciate that. Nothing about tariffs and Trump, okay? All right. So anyway, let's talk a little bit about the anatomy. Of course, we have Leonardo da Vinci here who does a great job of showing this anatomy. And more specifically, let's talk a little bit about the muscles involved. So when we talk about shoulder impingement syndrome, typically we're referring to a rotator cuff tendon pathology. And we all, of course, know what the rotator cuff muscles are: the sits muscles, supraspinatus, infraspinatus, teres minor, and subscapularis. And everyone should be well aware of the passageway of the supraspinatus muscle tendon along with the rest of the insertion of the sits tendons as they travel under the acromion and in between the bone and the subacromial bursa. This is kind of the area that is of concern when we talk about shoulder impingement syndrome. In a coronal plane, you can see very clearly what's going on. So here's the head of the humerus, right? You can see the hyaline cartilage, both on the humeral head and in the glenohumeral fossa. Now, it's important to understand that oftentimes with age, this cartilage will degenerate, like osteoarthritis, for example. Light therapy can actually help to restore some of that cartilage or repair or regenerate to some degree. So usually when you get people that have supraspinatus or shoulder impingement syndrome, they oftentimes will have degeneration in their shoulder joint as well. So that's important to understand. Now you can see the supraspinatus muscle, then the tendon, and then this very, very thin normal subacromial bursa. So a normal bursa is, it's a fluid-filled sac, but there's not a lot of fluid in there. It's only when it becomes swollen and inflamed that it actually starts to create take up a lot of volume because it's swollen, and therefore starts to impinge, as well as any swelling or issues with the tendon itself. So these are the issues, and you have, of course, the acromion overlying this. So the most important structures are these particular ones that I'm sharing right now. A recent stat indicates that shoulder impingement syndrome is believed to be the most common cause of shoulder pain, accounting for 44 to 65% of all shoulder complaints. This was, you can see the reference below, is probably, like I say, vast majority people come in with shoulder problems, especially in that age group. This is probably what's going on. So these sits muscles help to stabilize the GH joint, and of course they aid in movement from abduction, internal rotation, external rotation. And as I mentioned, tendinopathy is a very common cause of shoulder pain, specifically, or most common, the supraspinatus tendon, which is quite uniquely susceptible to compressive forces of subacromial impingement. Oftentimes it's due to improper, sports or athletic technique, poor posture, poor conditioning. Sometimes it's due to failure of the bursa itself to protect the supporting tendons. So you might start to get some acute inflammation. Eventually it leads to degenerative changes, as well as degenerative changes in the tendon, which takes up space or volume, like tendinosis. The easy way to think about that is when you have tendinosis in the Achilles tendon, it appears thickened, right? So if you've ever, I'm sure you've all seen Achilles tendinosis, and you look at right and left, you see the tendinotic tendon, it's actually larger and thicker. So imagine that underneath your acromion, taking up volume of space, reduces the ability of the head of the humerus and the tubercle to get out of the way or push through there when you're moving your shoulder, especially into abduction. As I mentioned, rotator cuff disorders are very common and account for up to 2/3 of all shoulder cases. And again, typically when we talk about rotator cuff tendinopathy, we're oftentimes referring to this as an impingement syndrome or subacromial impingement syndrome. They're kind of synonymous. It's not necessarily believed that the acromion itself is irritated. That's not really what's going on here. Only 50% of all patients diagnosed with rotator cuff tendinopathy seem to be fully recovered within the first 12 months. So think about that. When a patient comes in, you need to determine, okay, when did the symptoms start? What's a realistic treatment plan? How long is it going to take this patient to get better? You need to educate your patient. If they think they're going to walk out of there in a few weeks and be lickety split and go back to playing squash or whatever it is they're doing, it's not going to happen. And like, I mentioned squash. I play squash all the time, and I'm I'm nearly a senior citizen, believe it or not, and I play with a lot of people from 40s, 50s, 60s, even some guys in their 70s and 80s. And they'll come in and say, "Oh, my shoulder's killing me," and then they give it some rest, it's feeling a bit better, and they go back to it, and then they're out again, right? So it's really important to understand you want this to be healed properly, and you need to be given the appropriate time frame to do that. So it's up to you to determine what an appropriate treatment plan is going to look like, and it's not going to be a few weeks. The definitive cause and source of pain in rotator cuff tendinopathy is still a bit of a question mark. There's certain proposed mechanisms and tissues that are probably involved, right? So these include intrinsic, extrinsic, or a combination of factors. Extrinsic would be things like reduction of strength of the tendons, perhaps due to contact because of friction, poor function of the musculature, fatigue. So you can think about these when you're doing something repetitive, especially anyone that has a job that's repetitive in nature, whether that's in a factory or whatever you do for a living. Reduction of pain-related inhibition. So as you get older, the ability for your body to kind of block pain is reduced, and you feel pain more. That's kind of what that means. Structural incompetence. So basically reduction of that subacromial space for the moving parts in there. Intrinsic mechanisms that directly influence the tendon health and quality, including, of course, aging, genetics, vascular changes, altered loading patterns. We know that excessive tissue load remains the most common factor in the development of tendinopathy, and this is reflected by the fact that rotator cuff tendinopathy occurs more frequently in the dominant limb in occupations and in sports with high rates of upper limb loading. So you can imagine if you're right-handed and you're doing a lot of work with your arm above and abducted and rotating, you're going to have a higher degree of chance of having impingement in that specific limb, although oftentimes it can be bilateral. Another issue is underloading. So this may disrupt tendon homeostasis, potentially resulting in temporarily earlier point of failure when the tendon is subject to load. So in essence, when you underuse muscles and tendons, it become weaker and more potential for tears, right? And for injury. Although you wouldn't know that the way I fumbled that word. Asymptomatic partial and full thickness rotator cuff tendon tears have been reported in 50% of people by their 7th decade and in 80% of people over the age of 80 years of age. So it's going to happen. Current research evidence suggests people diagnosed with rotator cuff tendinopathy should expect an equivalent outcome to surgical intervention with a well-structured, graduated exercise program. So you add laser therapy or photobiomodulation or PBM, you'll do even better. So imagine that. You can go under the knife or probably get the same result or probably better if you don't, if you are very good at doing your exercises, right? So that's part of the rehab process is when you're working with your patients for subacromial impingement syndrome, you need to make sure that they're doing their exercises, doing them correctly, that you're giving them guidance, have them journal it, because if they're not doing it, they're just not going to recover very quickly. The hallmark characteristics of rotator cuff tendinopathy, of course, is pain and weakness, and this is typically during shoulder external rotation and elevation. A significant proportion of individuals with tendinopathy have pain radiating down their arm, and they may even have hyperalgesia, which is essentially increased pain with a stimulus that normally doesn't cause pain, right? So you touch around the shoulder area and they're like, "Ow, that really hurts." And it's like, well, dude, like I'm barely touching you. That's hyperalgesia. So it's interesting. There seems to be oftentimes central sensitization in patients with these types of issues. And so the pain experience may not always be related to a local pathology. So in other words, they may show the patterns of subacromial impingement syndrome, but but the shoulder checks out normal, right? And you do the testing and all the rest of it. There might be some central sensitization, which is a central nervous system, spinal cord issue, right? So it may become from the cervical spine. So you need to make sure you're assessing, of course, the neck as well as the shoulder complex, and perhaps there's other things going on as well. So again, this is a review. I know everyone knows this, but if you look at the painful arc in shoulder impingement, essentially this is, as they're abducting the shoulder, you get into that painful region where you get that pinching of the greater tubercle underneath the acromion and pinching the supraspinatus tendon and the typically inflamed subacromial bursa. They take up too much volume of space. And so when you try and clear the bone, it pushes into sensitive tissue, hence why it's so painful. And then you rotate out of that higher up and it's okay. So, that's a pretty common test to do that. Just to visualize that so you understand, you get essentially a tendinopathy where the volume of the tendon increases, taking up more space, and potentially the bursa also being inflamed and taking up more space. And that's where you have the problem. So I'm reiterating this because it's important when you're doing laser therapy, you want to target these areas, right? And there's techniques to doing that. You don't want to just put your laser probe on the acromion. That's pointless. You because you're getting light into the bone. You want to get it underneath the acromion as best you can, in and around the tendon, in and around the bursa, anterior, lateral, and posterior. You do that, you'll have the best result with light therapy. Again, my role here isn't to go over the exercises. You all know these exercises, and it's really critical for this type of issue to get better. This is the one time, not the one time, but this is a big thing I'll emphasize, is that for this specific issue is that they need to be doing the exercises to help with the condition. And there's, different types, and typically it's with, these rubber bands of different elasticity. Don't be overzealous with it. Sometimes it's like, oh, no pain, no gain. That's not what you're trying to do here. You're doing really specific exercises to help with the tissues regain strength and function here without killing the patient, right? We all know that sometimes patients give up or stop doing them, or stop seeing their rehab specialist because things are getting worse, and you need to make sure that they're doing them correctly. So again, I'm just showing you some examples here. I won't get into the details because you're free to look those up, and of course you already know them anyhow. Okay, well, this is about laser therapy, right? So let's get into why photobiomodulation therapy, or low-level laser therapy, or whatever name you want to call it, but I prefer PBMT because that's what is used in the research. And I know I say this all the time, but it's really important to understand what this light is doing. The light is being absorbed into the cells and the tissues and the cells inside the tissues, and it will have an impact on the function of these cells. When that light is absorbed, it helps with cells that are metabolically impaired due to inflammation and injury. So what happens in injury and inflammation is the cells have decreased capacity to make energy, or ATP. In part, that has to do with increased molecules like nitric oxide, for example, that inhibits or blocks the electron transport chain and production of ATP. By inducing light into these cells, it interacts and allows the nitric oxide to dissociate, allowing oxygen to bind back onto the cytochrome C oxidase, and allowing the electron transport chain to produce ATP. As you start to produce ATP, it has an impact on the sodium potassium pump, and a byproduct is a short spike of reactive oxygen species, or ROS. This has a trickle-down effect inside the cell, referred to as secondary and tertiary effects of the cell, that helps protect the cell from further damage. I won't get into the details, but that's part of how this is working. Nitric oxide, as it's being released, it freely dissociates outside the cell into localized blood vessels, extracellular space, and can cause temporary vasodilation and improve blood flow as well. Light can also interact directly with ion channels. This is a really fascinating new, not that new, but relatively new understanding of how photobiomodulation works. And we're thinking that longer wavelengths, like over 980 or over 1,000 nanometers, can directly affect these as well too, and have an impact. So I think you'll be seeing some changes and additions to wavelengths, not just the traditional, red and short near infrared, like, 800-ish, but also maybe slightly longer as well. Even though it is absorbed by water, it can also trigger these calcium ion channel effects a little bit more efficiently than some other wavelengths. Now, those longer wavelengths might not trigger the ATP effect as well, which is why you probably want to have a combination of different wavelengths. That's in part why we use red and near infrared. So ultimately, you're going to improve the capacity for regeneration, or mitosis. You're going to reduce inflammation by different mechanisms inside white blood cells that I haven't really mentioned. I mentioned about vasodilation. It does have an effect on circulating stem cells and white blood cells that help control inflammation and the repair process. It can reduce the volume of edema. So that's important because you reduce the volume of edema, you have better range of motion. And it can also reduce pain through inflammation. If you're using high dosages of light, you can block pain, but then you don't do photobiomodulation. So these are many of the effects of how photobiomodulation is going to help. Most of that is a direct effect, but there's also indirect effect on blood. And that's part of how we specialize, at least at BioFlex, our equipment, is that we surround the tissue that's injured, in this case, the shoulder area, right? With these large arrays of light. Now, that light's not going to penetrate deep into that subacromial region, but it will be very effective for treating the blood. I mean, some of the light will definitely penetrate, but not as much as a laser, for example. But this light, when you're surrounding that area and treating the blood that's constantly circulating right around the shoulder, and of course, feeding deeper into structures like the bursa and like the GH joint, then you actually help reduce inflammation and you actually help increase the number of circulating stem cells in that area to help repair and help reduce inflammation. So by surrounding that area with those sort of LED arrays, you're going to help with that shoulder issue, right? In this case, the impingement. So this is a really important factor. If you're listening in and you just have a personal system of just the array, still extremely effective for this condition. I do recommend, though, if you have this condition, that you also seek out a practitioner treatment as well in a clinical setting, because they'll have access to a class 3B laser that can drive the light even deeper into the joint. These are restricted to healthcare professionals because there's a certain level of risk involved with using it, and they are regulated devices. So the systemic effect, now what I just talked about was a direct effect, and the systemic effect is what I was just talking about. I got ahead of myself. Is the effect on blood. Now it can even go into the bone marrow, but it depends where you are in the with the bone. So most of the effect is in the blood in this case. But bone marrow can be affected as well if you can get light into the bone marrow. There's a fair amount of research on shoulder impingement syndrome and low-level laser therapy. This is just one particular paper published pretty recently called The Efficacy of Low-Level Laser Therapy Combined with Exercise. Smart, right? Gonna do your exercise. For subacromial impingement, it was a randomized controlled trial. A fairly robust number of subjects at 120. There were 3 intervention groups. They were either treated with low-level laser therapy and exercise, that was group 1, exercise only, that was group 2, or just laser therapy, that was group 3. And they were treated 3 times a week for 8 weeks. So that just gives an indication that it was designed well. They didn't try to treat a couple of weeks, right? This is a chronic condition. It's not going to respond in just, a week or two. 2 months solid treatment. Okay, this is what they did. They received, now in this case, they received 3 joules of energy of near infrared irradiated per point over 3 insertion points. So they only did 3 points. Over the supraspinatus muscle tendon on the subacromial bursa along the bicipital groove. So trying to get into that tissue area. Total dosage was 27 joules. Just to give you an idea, for those of you who are listening in and have the BioFlex professional equipment, if you want to provide, say, 3 joules of energy, that would be roughly, and setting at 100% power for the LDI 200, that's about 20 seconds, 17, 20 seconds of treatment time. If you lowered it to 50%, then you would hold it for about 40 seconds, okay? I always prefer lowering the power and holding it for longer. And the reason for that is that the longer, it's not going to go any deeper just because you increase the power. That's not actually, that's a misnomer. But if you hold it there for longer, more light will accumulate to that greater depth and give the tissues a chance to absorb the light and do something with it. I use the same analogy all the time. If you're trying to water a dry plant and you have your cup of water and you just quickly pour it over the plant, well, it's going to absorb some quickly, but then it's also going to spill over and not be overly effective. You're way better off to slowly add the water, let it absorb, add a bit more, let it absorb, add a bit more. I think we've all been there, done that to understand that concept. Exactly the same for photobiomodulation therapy. Hate to break the news to anyone listening in that believes more power is greater results. That's not what all the research shows. So that's not the case. I say that a little bit um, facetiously, you might say. In the first stage, they did first 6 sessions. They did stretching of the traps, the pec, the posterior and inferior shoulder structures. They did isometric exercises. Humeral thruster and scapular stabilizer muscle groups were performed. They also did, that was in the first sort of stage, first 6 sessions of stretching. Then they added other types and for longer and more repetitions and with weight as well. And then finally, they added even more weight or resistance to their exercises. And here are the results. You can see, remember, group 1 was laser and exercises, right? Group 3 was laser only. Group 2 was exercise only. And so it's interesting to note. So if you look at the baseline, the pain was roughly a 7 out of 10, right? Or 6.6 or 6.5 for the different groups. And then post-treatment, right? The pain went down to 0.2, so pretty much not there at all with exercise and laser therapy. And with exercise, it went down to 0.5. It was still a really good effect, but not quite as good as with laser therapy. And then you can see just with laser therapy, it didn't have nearly as good an effect. And this is just a great case to show you need to do that exercise therapy. And you can see the other results are consistently better when you combine exercise and laser therapy as opposed to just one or the other. Okay, so typically that's how you're going to do it, is you're going to add laser therapy along with other types of treatment regimes, whether it's exercise, whether it's shock wave, whether it's manual therapy, whether it's manipulation, whatever it is, typically you're going to do other types of treatment as well in combination. And then you can see the follow-up results as well with respect to range of motion. You can see shoulder flexion at the start was 133, and then it increased to 161 and ended up at 153. And you can sort of read and see all the results as well. I won't go over each one, but it's pretty clear that there's much better results combining the two than just doing one or the other therapy. So in conclusion for this paper, their findings suggest that low-level laser therapy combined with muscle strengthening exercises reduced pain intensity, improved shoulder function, and they also, I didn't talk about this, but reduction of medication as well over a period of 3 months. So they did the treatment for 2 months, and they did a follow-up 1 month later. So over 3 months that they were following or tracking these patients. So in 3 months, you can imagine that the patient was actually after 2 months, the patient was pretty good. I would still continue to treat. I would give it a 3-month range of a treatment plan for most cases, with the understanding that within 6 to 8 weeks, you're going to have significant improvement. But I would continue to treat, maybe not 3 times a week, maybe once or twice a week, that remainder of that month to ensure that they're recovering appropriately. Okay, so let's talk a little bit about how you're going to use your equipment. Now, again, this is geared for healthcare professionals, so you're going to have both the large surface array dual pad as well as class 3B lasers. Those of you who are listening in that just have personal home systems, that's pretty similar to what this array is that I'm showing you on the left. The protocol looks something like this. Now, I do want to mention that the protocol for rotator cuff tendinopathy is a little bit lower parameters than a generalized shoulder protocol. And it starts off with a pretty low pulse rate of 10 hertz for the infrared and a pretty low duty cycle of 40 hertz. in general, I find these patients to be quite sensitive to treatment. I'm not 100% sure why, but the preset software will choose 10 hertz. No, I mean, I know why we choose 10 and 40 hertz. I'm not necessarily sure why they're more sensitive to treatment, but it seems that way, which is why we start at a relatively low pulse rate at 10 and a relatively low duty cycle at 40%. Now remember, duty cycle represents the amount of energy or light coming out of your equipment. So it's like a dimmer switch. The higher the percent, the duty cycle, the greater the strength of light, or the brighter the light is, or the more energy coming out. So 1040 is what we start off with. And then within stage one, you can start to customize and increase the frequency if the patient is plateauing or not responding to that initial 1040 dose. So maybe take it up to 2050, 2060, around there. That's where you can customize these protocols. To be honest, what I do with these protocols is, even though I have stage 1, 2, and 3, I'll take stage 1 and make 2 protocols. So I'll call stage 1A, stage 1B. Stage 1B is 20 hertz and say 60 hertz. So 1A is 1040, 1B is 2060. So now I have 2 protocols in that stage 1. Then I can go to stage 2. And at that point, I'm starting a little bit higher now at 30 pulses per second. Now I'm at 60% duty cycle. And then I can have stage 2A and then stage 2B, which might be around 50 pulses per second and a higher duty cycle at 80%. I'm not going to talk too much about the red. We do pulse it a little bit. The red does not get into the joint. It's not going to have an effect with the tendons or the subacromial space. The red light is really meant for a systemic effect. And so, we do alter it a little bit, but it's not going to have any profound effect inside and deeper areas. And then finally, stage 3, by the way, most of the time, I'm going to say 1A, 1B, and 2A, 2B is going to be all that you need. If you're finding you need to actually stimulate even more, you can go to stage 3, and there you can see the pulse rates are much higher, with the highest duty cycle at around 90. Okay, so that's kind of your last option. But typically, you're going to give each sort of protocol at least 3 sessions, and if they're responding, keep it at that level. If they're responding and then plateau, meaning that they're not getting much better anymore or slow to get better compared to the first few sessions, then sure, stimulate a little bit more. I hope everyone's clear on that. I'm just going to take a quick break here and make sure, by a show of hands in the chat box or wherever you want to do, does this make sense to everyone out there? Because I want to make sure that everyone is understanding what I'm getting at here. Okay, awesome. So pretty simple, right? Even though I haven't showed it here for clarity, I would use the weight that you have, if they're tolerated, to put it over the array, to push the array into the skin to allow for better contact. So the first position is anteriorly, where the main focus of the light is literally at the chromion and inferior to it, so the light can kind of get into that general area that I've shown that red circle. The second position is lateral. You'd probably be better to adduct here and allow the light to penetrate again underneath the acromion through the deltoid and into that tissue as best as possible. Again, it's not going to go super deep with respect to the array. And then the posterior one, again, you're going to focus on the rotator, the teres minor and the infraspinatus insertion on the posterior aspect of the joint. So again, treat around the entire area, start with lower frequencies, lower duty cycles. That's stage 1. The LDI 200 is set at 75 milliwatts approximately. So if you want to put out 3 joules of energy, which is what that paper used, that's about 40 seconds. I would say this, that if that's not doing it for you, increase the time from maybe 40 to 50 seconds per point. You may need to hold a little bit longer. Don't forget, you should depress or push in the laser probe as much as they can tolerate so you can get the tip of the probe closer to the target area. In this case, the subacromial space and the insertion of the rotator cuff tendon. Stage 2 and 3, they'll have full 100% power of the LDI 200, so you can back off a little bit on how long you hold the probe. My preference again is actually to not increase, is to actually reduce the power. Instead of 100%, I'm going to customize it and lower the power. I like holding it longer than higher power and shorter treatment time. I just find more effective. And again, remember, you're going to target the tendon from different angles, as well as any tender or trigger points in and around the sits muscles. Focus the laser probe on the pathological tissue that needs to be healed. If you have an LDR 100, which is the red laser probe, the light here is not going to go into this area at all, but it's very great. It's really beneficial for pain control. There, I'm going to set it for 100% power, 20 to 40 seconds per point, especially over tender or painful areas. If you don't have an LDR 100, I would consider adding it to your toolbox with your equipment. So, if you're interested in that, you can reach out to our sales team or what have you. But I firmly believe that that's something that adds to your treatment by adding the LDR 100 as well. Don't forget to move the GH joint in different positions to expose the rotator cuff. Specifically, adduction exposes a supraspinatus tendon. And of course, you're going to add manual therapy and exercises. That's a no-brainer. And again, you look at the C-spine and make sure that there's nothing going on there. Sometimes that needs to be treated as well. Once you've used a laser probe around the area, if there's still some time left, I would go back to the common tendon and treat a little bit more as well. So again, if you're looking at where to treat and visualize, this is the anterior aspect. I don't think I need to show everyone understanding of where the structures are. You're trying to get light into this area. Okay, that's where you should be focusing on with the laser probe. And laterally, again, you're going to adduct the shoulder, and you're going to treat just on the inferior lip of the acromion. Okay. And then lastly, posterior approach, you're going to treat the supraspinatus tendon and just underneath the margin of the acromion, and any cyst muscles that are tender upon palpation and so forth. All right. Hopefully you enjoyed today's webinar. Next webinar is very interesting. We have a new product coming out. We actually, this is pretty cool. So it's the first ever, I guarantee you this, but there's others out there, but not like this. This combines red and near infrared cupping device. It's an electronic cupping device. You'll see them out there on the market, and some do add some red light therapy, but we've actually designed one that has both red and near infrared that go into the tissue. So when these work, just like if you do cupping, by the way, let me know if you can do this, it'd be great. Let me know in chat box if you do cupping, or maybe you're interested in cupping. There are definite benefits to it physiologically to help with microcirculation, but when this works, and it's really cool how it works, is that, it draws the skin and the tissue upwards. As it's doing that touches or comes very close and touches the LEDs that will then be emitting red and near infrared light into the tissue. And of course, you have all that blood that's coming through that area as well too. So it makes a great way of getting light into that area. It's called the BioFlex Wave Surge. It's basically, you can use it at home as a consumer device. You can also use it in a professional setting. So if you're interested in that, we'll be launching that very soon. I'll have this webinar on all the details about that. We also have a webinar on treating post-concussion syndrome. This is right before I take off to Vancouver, and we're doing a Light Up Your Practice in Vancouver, but we're also doing an advanced training on post-concussion therapy. We have guest lecturers from Vielight. If you have heard about Vielight, they're a specialized transcranial photobiomodulation company that we're sort of working together with. So some of their great research is going to be presented, and along with some of their equipment as well. And I've yet to confirm, but I'm hoping to confirm Dr. Ashley Banjan from South Africa, who's done tremendous work. He's a neurologist using BioFlex for TBIs or traumatic brain injuries, including concussions. So we'll be a guest speaker as well. I'm seeing if we can do this as a live event. I'm not quite sure yet. I'm hoping at least that we can record the event for people that can't get out to Vancouver to watch that. Okay, awesome. So then, oh, David Barker, that's awesome. You use cupping all the time. Maybe, David, reach out to me because I just want to pick your brain a little bit about that. And that's about it. So hopefully everyone enjoyed today's webinar. It was great to see everyone out. Have a great afternoon, and hopefully we'll see you at the next webinar. Bye now.